Hello everyone, now let us discuss about pharmacology of H1 antagonist, which are nothing but conventional antihistaminics. Now first coming to the classification of H1 antagonist, they are categorized based on the sedation they produce. They are highly sedative, moderately sedative, mildly sedative and second generation which are non-sedating antihistaminics. Coming to highly sedative antihistaminics, they are diphenhydramine, dimenhydrinate, promethazine, hydroxyzine. Drugs which are moderately selective, they are phenyramine, cyproheptadine, meclizine and cinnarizine. And drugs which are mildly sedative are chlorpheniramine, dexchlorpheniramine, trifluridine and clemastine. Coming to the second generation antihistaminics, they are non-sedating. Examples are fexofenadine, loratadine, desloratadine, cetirizine, levocetirizine, azilastine, misolastine, ibastine and rupatadine. Coming to the pharmacological actions, the first is antagonism of histamine. Antagonism of histamine. As the name indicates, they are H1 receptor antagonists. So they block the histamine-induced actions, which are nothing but they block bronchoconstriction, contraction of intestinal and other smooth muscles. They block the triple response which is produced by histamine, that is wheal, flare and itch. And fall in BP produced by low doses of histamine is blocked by H1 receptor antagonist. But the fall in BP which is produced by IV administration of histamine, to antagonize that, both H1 and H2 receptor antagonist must be used. And they block the release of adrenaline from adrenal medulla and constriction of large blood vessels. These are the various actions that are blocked by antihistaminics. The next is anti-allergic action. Urticaria, itching and angioedema of immediate hypersensitivity reactions are well controlled by H1 receptor antagonist, whereas anaphylactic fall in BP is only partially prevented. Coming to the actions on CNS, older histamines produce variable degrees of CNS depression. That is, they are BBB permeable and its affinity because of the blood-brain barrier permeability and their affinity for central H1 receptors. And some individuals also experience stimulant effects like restlessness and insomnia. Excitement and convulsions are frequently seen at toxic doses. And the second generation antihistaminics are practically non-sedating. And certain H1 antihistaminics are effective in preventing the motion sickness. Promethazine controls vomiting of pregnancy. It reduces the tremor, rigidity and siluria of Parkinsonism. These are some of the central actions of promethazine. It controls the vomiting of pregnancy and it reduces the tremor, rigidity and siluria of Parkinsonism. Whereas cyproheptadine has appetite stimulant effect. That it increases the appetite. And some H1 antihistaminics are also effective as antitussives. Coming to anticholinergic action. Many H1 blockers, in addition to histamine blockage, they antagonize muscarinic actions of ACH. And the anticholinergic action can be graded as follows. The drugs which have high anticholinergic action are promethazine, diphenhydramine, dimenhydrinate, phenyramine and cyproheptadine. Which have low anticholinergic action are chlorpheniramine, hydroxyzine, trifluridine, cyclizine. Which have minimal or absent effect anticholinergic action are fexofenadine, astimizole, loratadine, cetirizine and misolastine. If used concurrently, whenever antihistaminics, if they are used concurrently with atropine or its substitutes or phenothiazines or tricyclic antidepressants or disopyramide, the anticholinergic action adds up. Coming to local anesthetic effect. Some drugs like phenyramine, promethazine and diphenhydramine have strong membrane stabilizing property. but they are not suitable for subcutaneous administration due to their irritant activity. For that reason, they are not typically employed as local anesthetics, and the membrane stabilizing activity also confers the antiarrhythmic property to these compounds. Coming to the effect on BP, most antihistaminics cause fall in BP on IV injection, direct smooth muscle relaxation, or alpha adrenergic blockage. Whereas promethazine has significant alpha adrenergic blocking activity also. However, this is not evident on oral administration. Most of the antihistaminics, they cause a fall in BP on IV injection, and this is not evident on oral administration. Fall in BP is mainly caused by direct smooth muscle relaxation or alpha adrenergic blockage action. Coming to the pharmacokinetics of antihistaminics. The H1 antihistaminics are well absorbed from oral and parenteral route. They are metabolized in liver and excreted in urine. They are widely distributed in the body and they can cross blood-brain barrier. Newer compounds penetrate blood-brain barrier poorly because of their low or absent, this accounts for their low or absent sedating action. The sedating action is mainly seen because they penetrate the blood-brain barrier, whereas the newer compounds, which are second generation antihistaminics, they penetrate brain poorly, and this accounts for their low or absent sedating action. And the duration of action is usually 4 to 6 hours. There are certain long-acting drugs, for example, meclizine, loratadine, cetirizine, and fexofenadine, whose duration of action ranges from 12 to 24 hours or more. Coming to the side effects. The various side effects of antihistaminics are, first one is sedation, diminished alteration, alertness and concentration, lightheadedness, motor incoordination, fatigue and tendency to fall asleep, impairment of psychomotor performance. Because of the motor incoordination and impairment of psychomotor performance, patients or individuals are not advised to operate any vehicles whenever they are under antihistaminics. And fewer individuals become restlessness, nervous, and they are unable to sleep, which is nothing but insomnia. Other side effects are dryness of mouth, alteration of bowel movement, urinary hesitancy, and blurring of vision can be ascribed to anticholinergic property. Epigastric distress and headache are also seen. Local application can cause contact dermatitis. They are contraindicated for regular use in children due to their CNS depressant property, which can affect the learning capacity of the children. Coming to the toxicity, acute overdose of antihistaminics produces central excitation, tremors, hallucinations, muscular incoordination, convulsions, flushing, hypotension, fever, and some features of belladonna poisoning. Death can occur due to respiratory and cardiovascular failure. Coming to second generation antihistaminics. The second generation antihistaminics are defined as those H1 receptor blockers that have one or more of the following property. The first is they have higher H1 selectivity. This contributes to no anticholinergic side effects and absence of CNS depressant property. Additional anti-allergic mechanisms apart from histamine blockage are seen. Some of them also inhibit the late phase allergic reaction by acting on leukotrienes and by antiplatelet activating factor effect. They does not impair psychomotor performance. These are some of the added advantages of second generation antihistaminics. Coming to the drugs. The first is fexofenadine. It is an active metabolite of terfenadine. It poorly penetrates blood-brain barrier. Hence, it does not have any cholinergic side effects. It has minimal sedation or impairment of psychomotor performance. Duration of action is 24 hours and the plasma T-half is 11 to 16 hours. Coming to the contraindication. It causes ventricular arrhythmias in patients with pre-existing long QT interval. Thus, it is not entirely safe in patients with prolonged QT or bradycardia or hypokalemia. Fexofenadine is contraindicated in patients who have prolonged QT interval, bradycardia or hypokalemia because it can cause ventricular arrhythmias. The next drug is loratadine. It is a long-lasting H1 antagonist. It is an active metabolite, has a longer T-half of 17 hours. It has an active metabolite which contributes to the longer T half of 17 hours. Overdose may result in seizures, and it has good efficacy. Loratadine has good efficacy in urticaria and atopic dermatitis. The next drug is desloratadine. It is a major active metabolite of loratadine, effective at half of its dose. And non-interference with psychomotor performance and cardiac safety are documented with desloratadine. The next drug is cetirizine. It is a metabolite of hydroxyzine, which with marked affinity for peripheral H1 receptors. Its T half is 7 to 10 hours. It penetrates brain poorly, but mild sedation and subjective somnolence are experienced in many excipients. Cetirizine inhibits the release of cytotoxic mediators from the platelet as well as eosinophilic chemotaxis during the secondary phase of allergic responses. For that reason, it is majorly given for allergic conditions. Coming to the uses of cetirizine, it is used for upper respiratory allergies, pollinosis, urticaria and atopic dermatitis, adjuvant in seasonal asthma. This is one more important clinical use. Cetirizine is used as an adjuvant in seasonal asthma. Next is levocetirizine. It is an active R-enantiomer of cetirizine. It is effective at half the dose and appears to produce fewer side effects. The next is azilastine. This H1 blocker has good topical activity. In addition, it inhibits histamine release and anti-inflammatory reaction triggered by leukotrienes and platelet activating factor. It has bronchodilator property also, and its T half is 24 hours. The adverse effects of azilastine are stinging in the nose, altered taste perception, somnolence on nasal application. It is given as a nasal spray. So somnolence is seen on stinging in the nose, altered taste perception and somnolence. All three are seen on nasal application, whereas weight gain can be seen after oral use. The next drug is mesolastine. It is non-sedating antihistaminic and is effective in allergic rhinitis and urticaria by single dosing despite a T half of 8 to 10 hours, and it does not have any active metabolites. The next drug is ibastine. It is rapidly gets converted to active metabolite carbastine. It has a T half of 10 to 16 hours. It is non-sedating and active in nasal and skin allergies. The next drug is rupatadine. It is an antihistaminic that has additional platelet activating factor antagonistic property, and it is indicated in allergic rhinitis. The next drug is cinnarizine. It is an antihistamine, has additional weak antimuscarinic, anti-5-HT, sedative and vasodilator properties. Anti-vertigo property may be due to the calcium channel blockage of cinnarizine. Beneficial effects are reported in Meniere's disease. Side effects of cinnarizine are sedation and mild GI upset. It is used as an adjuvant in the treatment of vertigo. Next is prochlorperazine. It is a D2 receptor, dopamine receptor blocking neuroleptic that has additional antihistaminic and labyrinthine suppressant property. This is also used to treat vertigo. Both the drugs, cinnarizine and prochlorperazine. Parenteral prochlorperazine is most effective drug for controlling violent vertigo and vomiting, whereas prochlorperazine is also used to treat other types of vomitings also. Now coming to the overall uses of antihistaminic drugs. First is allergic disorders. They are only indicated for palliative use. Antihistaminics in allergic disorders are only indicated for palliative use. They are effective in controlling certain immediate type of allergies. For example, itching, urticaria, seasonal hay fever, allergic conjunctivitis and angioedema of lips, eyelids, etc. IV use of antihistaminic may have an adjuvant value. IV use of antihistaminic may have an adjuvant value in laryngeal angioedema and anaphylactic shock, where adrenaline is the drug of choice. Adrenaline is a life-saving drug in laryngeal angioedema, but antihistaminic, IV use of antihistaminic can be used as an adjuvant in the treatment of laryngeal angioedema and also to treat anaphylactic shock. In both the cases, adrenaline is a drug of choice. The next is cetirizine is used as an adjuvant in seasonal asthma. Usually antihistaminics they suppress urticaria and swelling in serum sickness. Now coming to other conditions involving histamine. Symptomatic relief in insect bite and IV poisoning is seen with antihistaminics. Abnormal dermographism can be suppressed. They have a prophylactic value in blood and saline infused trigger. The next is as pure diets. Older histaminics like chlorpheniramine, diphenhydramine and cyproheptadine, they remain the first drug of choice for idiopathic pruritus. Coming to the use in common cold, they afford symptomatic relief by anticholinergic, that is reduces the rhinorrhea and sedative actions. Whereas second generation drugs which are non-sedating, they are not that effective in the treatment of common cold. Now coming to motion sickness. Promethazine, diphenhydramine and dimenhydrinate and cyclizine have prophylactic value in milder types of motion sickness and they must be administered 1 hour before the journey. An off-label use of cyproheptadine is often made in anorectic and convalescent patients for improving the appetite. But this is always off-label. That is, it is not usually prescribed. Now coming to vertigo. Antihistaminics, they are employed as labyrinthine or vestibular suppressant medications. The labyrinthine suppressant medications are the principal drug for the management of vertigo as well as that of attendant nausea and vomiting. The H1 antihistaminics, cinnarizine and dimenhydrinate are the most commonly used vestibular suppressants in this condition. Beta histine is specifically used in Meniere's disease. Now coming to the effect as pre-anesthetic medication. Promethazine has been used for its anticholinergic and sedative properties as a pre-anesthetic medication in some cases. Coming to cough. Chlorpheniramine, diphenhydramine and promethazine afford symptomatic relief by sedation and anticholinergic properties in the treatment of cough. Now coming to Parkinsonism, promethazine and some other drugs afford mild symptomatic relief in early cases based on their anticholinergic and sedative properties. Next is acute muscle dystonia. It is promptly relieved by parenteral promethazine or hydroxyzine based on the central cholinergic action. Next is antisedative, hypnotic and anxiolytic. Hydroxyzine has been used to treat anxiety associated with autonomic manifestations. And it is contraindicated to be used as sedative in children aged 2 years or less because it causes respiratory depression. Use of antihistaminics as sedative is contraindicated to be used in children aged 2 years or less because it can cause respiratory depression. Thank you for watching. Please subscribe for further videos on pharmacology and other related pharmaceutical sciences.